And so I do a lot of research. I've done clinical work with kids, so I kind of have a pretty good background in terms of this area. So in terms of what I'll be doing, the document that I had you read, just those different sections within the OHRP document. And so this is the Office of Human Research Protections. So this office was created to make sure when you do research with humans that you're doing so ethically. In the past, there have been lots of ethical issues in terms of what individuals do with people in terms of research, medical practices. I will talk about some of those examples. So there are a lot of ethical practices that need to be accounted for and need to be taken into account when working with pediatric populations. As you notice from that document, the pediatric population is a protected population. So they're higher risk, they're more vulnerable to different unethical practices occurring. So a lot of protections go into effect when working with the pediatric population. I'll talk about some clinical research, social research, ethics of exercise testing and prescription, and then some examples and consequences of unethical research. So that document that I had you read, I'll go over just the bigger points that I want to emphasize in a couple minutes. But first, I want to talk to you about institutional review boards. If any of you have been involved in research at UT, so if you've worked in somebody's lab on campus, you are probably familiar with the institutional review board. The IRB is also known as an ethics committee. And so this is a group of individuals, typically faculty members. There has to be a physician on the board. There's also a representative from the penal system, the prison system, because the people in jail are also considered one of those protected populations, because in the past, individuals have taken advantage of their situation and have done unethical things in terms of research. So these IRBs are in place in order to make sure everything that's going on with research being done is ethical in nature. Every study I have to do, I go through this board. I do pretty low risk research, so I do what's considered an expedited review, where I submit my protocol. A couple of individuals from the board will review the protocol, and then if it's ethical, they will provide approval. In some cases, I've had to go through what they consider a full board application, and that's when there's a risk that is greater than what a child would typically experience. So one of my studies that went through this full board was when I had kids doing a VO2 peak test. So that means they're running on the treadmill until they can't go anymore, until they reach volitional exhaustion. Anytime someone exercises at a very high intensity, there's risk of injury as well as risk of death. So because the risk was higher than what kids would normally experience, I had to go through the full board protocol. So everyone on the board sees the protocol. They have a meeting, they talk about the protocol and determine whether the risk is worth whether the risks and the benefits are equally balanced. And if the risk is too high, then typically they don't approve the protocol. But in the case of the exercise testing, we go through different channels to make sure the kids are safe. So we do a health history form. We ask parents about any previous injuries or conditions that may predispose them to being injured. And because we go through all those extra steps, they have given us permission to do those types of studies. So in terms of protection of human subjects, there are lots of definitions in that article. They talk about children. So children are, through this article, are typically defined as anyone under the age of consent or 18 years of age. So anyone who's not considered a legal adult. Level of risk, try to keep the, make sure there's a really good balance of risks versus benefits. So if there's a higher risk, there should be more benefit. An example that would be a clinical intervention or a trial. So you've heard of drug trials, medical intervention trials. Typically, those are done to try to better the condition or better the life of the child or the individual. If there starts becoming higher risk or they start seeing adverse outcomes, that's considered a high-risk study, and typically there are lots of protections in place and frequent review to make sure that the risk is not too high. So if there's an intervention being done and multiple individuals are getting more sick or there are deaths occurring, there usually will be an investigation to determine whether or not that study is really benefiting, or that intervention or drug is benefiting the individuals. Whenever you work with children, so anyone in that pediatric population under 18 years of age, you do need permission from the parents or guardians in order to do that research on the individuals. There are a few times where there are exceptions to this rule. So if you have a student in college and they are 17, they are eligible to be able to provide their own permission or their own consent. Also, if you have a population where there may be information reporting, so if a child is a ward of the state, they may be able to provide their own permission if the risk is low enough. So I'm going to go through an example of a parental permission form and the consent process. So I'm just going to share. Let's see. So you should be able to. Now I can't find the video where you guys can't see you all. Just someone yell out, can you see parental permission form on my screen?
Yes.
Okay, thank you. So I'm gonna make this a little bit bigger. I don't know if you'll be able, everyone can see this. Okay, so parental permission form, or that consent form, talks about different aspects of the study that you need to tell the parent or guardian so that they can make an informed decision of whether or not they want their child to participate in the study. So if any of you have participated in research studies on campus, you will have done one of these, read through and signed off. Making sure you read through the entire document is very important because this gives you a lot of vital information. When I work with parents, I typically send this ahead of time so that they can read it before they come in for assessments. And then I ask them if they have any questions, and I kind of repeat the the more important topics, especially the risks associated with the study, when I go through that information with them. So you always list who are the investigators on the project. So this project that we're currently doing, we're looking at motor proficiency in youth with and without autism spectrum disorder, using 2 different methods. So this is kind of a double whammy in terms of protected populations, because you have the pediatric population, and then you also have a population with disability, which may impact their ability to properly think through and give their consent. So it's really important that we get parent permission and the parents understand what we're going to do. So we talk to them about, or we provide information on wanting to have them be in the study and that they have to give their permission. If parents do not want the kids to be in the study, we let them know that it's not going to affect their rights or any care or services they receive. So this study that we're doing right now, we are currently recruiting in schools. So we have one school district that has agreed to let us recruit there. And so we just let them know, if you do not want your child to participate, they're still going to receive all the normal care, all the services at school, that this really is an optional thing. And so why are they being asked? And we just let them know that their kid is within the range and the population that we're looking for in this study. So age range 5 to 12 years old. So we're targeting elementary school kids, either diagnosed with autism spectrum disorder or no diagnosis, and they have to be able to walk because of the assessment tool, the motor proficiency tool. They have to be ambulatory. Research studies, so we want to compare 2 different methods of administering this assessment. So the assessment is a motor assessment. They do fine motor skill activity, gross motor skill, strengthening activities. And we are doing the traditional administration, as well as using a social narrative, which is it's essentially a story. So we tell the kids a story, and within the story, they do these different activities. Part of this ethical administration of a protocol is making sure that you don't waste people's time. So we're going to do 2 visits, approximately 75 minutes each. Based on my work with kids with disabilities and this particular assessment, it can take kids up to an hour to do this assessment. Most kids, it's going to take 15 to 20 minutes, but we always have to err on the side of caution and go with the longest time frame. So about 2.5 hours over a 10-day time period. So there'll be 2 visits, at least 1 day apart, but no more than 10 days between the visits. So again, we have to reiterate how much time is going to be spent in the study. And so this form is the one for what's going to occur on campus. And then we also have one specific to the school. We also, because we have a hard time getting people on campus, I'm sure you all know about the parking situation on campus. We have now permission to go to public areas, recreational areas, or even to people's houses to be able to do the research study. If they say yes, we outline everything that the child will do in the study. So this just gives an example of the different activities that the kids will do during the study. We've kind of added a couple extra assessments. They'll do a balance test, so that they'll do it the traditional way, and then they'll also do the balance test on a force plate, so that we can get some extra information. Also, we're going to record them. Whenever you add video recording, that adds a level of risk and can potentially reduce and anonymity, so kind of a breach of confidentiality. For this study, we just need to record to be able to start and see where the activity starts and stops for analysis of those force plate data. So when we video record, we're just doing from the waist down to the feet. So that eliminates the ability to identify any children. And then an extra thing that we added is that they will write in terms of their fine motor on a tablet using a special pen, so that way we can analyze how much pressure they put while they're going through these different writing tests. And then we just talk about what they're going to do on their second visit. If they say no, again, doesn't affect their relationship with us. And we've also included a statement that it does not affect the relationship with their school. What happens if they say yes, but then change their mind? We have had this happen a few times. If that's the case, they can stop at any time. And when whatever data we have collected, we will destroy and not use those data in our analysis if they decide to withdraw from the study. A big thing is talking about any risks. So you have to think about any risk that may occur during the study. So risks are minimal in this study. It's anything. So the risk is pretty similar to what kids would normally face when they do activity. And actually, because it's a controlled environment, there's actually a reduction in risk. So some of the things that may happen to them, so if they're doing some of our gross motor assessments, they may get leg cramps, they may fall, they may strain or sprain their muscle. We have not, knock on wood, have any of this happen during our studies. I did have one adverse event occur during a VO2 test where the kid was doing the beep test or the pacer test and threw up during the test. He had not been feeling well all day, neglected to tell us. And so, so after that, if you do have an event like that, an adverse event occurring, you do need to report that to the ethics board, and then you need to come up with what your plan's going to be to help reduce that risk. So in that case, before anyone did the study, we asked them, were they having, how were they feeling that day? If they were feeling any nauseousness or sickness, and then if they were, then we just move their assessment to another day. We also let them know that we're CPR certified, and that if there are any abnormal feelings, to let us know. That way we can make adjustments so that they do not experience any of those injuries. And we also have to let them know there's a risk of loss of confidentiality. We do a really good job of keeping our records anonymous, not having identifying information on there. So that risk is considered minimal. Most of the stuff I do, if we're doing just these observational studies, do not have a direct benefit to the child that's taking part in the study. It may benefit others with the results we find as we create new programs or new ways of assessing individuals, but generally there's no big benefit to kids participating in these studies. We have to talk about how we're going to keep everything confidential, what's going to happen to the kids' information after the study is over. We typically keep their information in case we need to reanalyze the data, and then we let them know that we will keep that information, and that if we reuse their data, we don't have to ask permission again. And that just makes things easier on the parents as well as easier on us. We do not typically pay our kids to be in the study. Sometimes we will give them little incentives like t-shirts or stickers. But for the most part, we don't pay individuals to be in these studies. No cost to be in the study. We have to include information about who can answer any questions related to the study. So I give my email, phone number. I have had people call. If they want to talk to someone else other than the research team, they have the information for the ethics board. Then they have to give permission. So we have them print the child's name, print their name, and then sign off. And then you need an extra permission for using images. So that would be video recordings, still images. So you need a second permission for that to occur. And I usually have the parents fill out information related to the health of the child and some of the more sensitive information, because sometimes we may not see the parents during data collection. So for this study, we asked specifically about autism spectrum disorder, what level they are in terms of their diagnosis, because if they're at a level 3, they are not eligible for the study. And we also asked if they're diagnosed with a secondary disability. And then we ask information related to their race and ethnic background. So that is just an example of the permission form that we have the parents sign before we can do the study. Let me get back to my PowerPoint slides. So we need parental permission to do anything in the study. In addition to that, we need assent from the child. So that says that the child wants to participate. So there are some restrictions in terms of assent. I do a lot of work with preschool kids. They cannot understand or comprehend signing off and giving their assent. So typically if we tell them what that we're doing and they actively participate, that is implied assent. If kids are age 7 and older, we have them sign an assent form. And if we're working with kids with disabilities who may not have the capability to understand the assent form, again, if they just participate, that is considered applied assent. So methodology is one of the big components, and the risks versus benefits. So does anyone have questions related to the consent process when working with kids? So again, everyone needs parental permission. 7 and older will provide written assent. Others can give verbal assent or just participate in the activity. And if you have an individual with an intellectual developmental disability, they're kind of, that's kind of a case-by-case assessment to determine if they can truly provide assent. All right, I'm going to move on if there are no questions. So in terms of ethics and research, we can talk about ethics in a couple of different situations. The ones that you may be more familiar with in terms of clinical would be clinical trials. So I briefly mentioned the clinical trials where there may be a pharmacological intervention or some sort of medical intervention, whether it's trying maybe some cardiac rehabilitation after heart surgery in a pediatric population, or it could be some sort of orthosis that helps a child to move. So clinical trials will look at the efficacy of those drugs or interventions. In terms of applied research, we're mostly dealing with maybe doing a physical activity program, doing some sort of nutritional intervention. So not necessarily a clinical trial, more what's going on in terms of what's going to happen on a typical day-to-day basis. Social research, most of the social research that we see and that involve kids are things that happen in the school setting, so educational research. So in terms of doing things ethically there are certain assumptions about youth. It's that they are a protected population. They're more vulnerable, especially when they're in a setting without their parents or guardians. And in terms of kids, you have differences in development and maturation amongst your group of kids. So you may have a group of 6th graders and they may be across the board, some with higher levels of maturity, others with lower levels. So you need to take that into consideration, that kids all don't grow, develop, and mature at the same rate. So you're going to have those differences. Within the school setting, again, you're going to have lots of individuals who are worrying about the welfare of the kids. So that's generally a pretty low risk area in terms of doing research. One thing to keep in mind is when individuals in the schools are doing research with kids, that they do a good job of protecting the confidentiality or the integrity of the data working with kids. So in those settings, you will see a lot of data being processed in terms of educational research, and that is typically done with no identifiers of the kids. Schools do have sensitive information that they can use within their research. So one example would be the socioeconomic status of the parents. If you have kids eligible for free and reduced lunch, the school has that information so that they have an idea of parents that are kind of lower socioeconomic status versus parents that are going to be higher socioeconomic status. And again, that's sensitive information, and the schools do a really good job of protecting that information and not revealing any specific details about kids. So there are a few studies involving unethical research with kids. So this research was done many years ago. These studies were done in the past. Because of the unethical nature of some of these studies, this is where more of the protections came into play. And I'll talk about some of the issues that we have now in terms of research ethics and working with children. So just a couple of examples. The Willowbrook study was a study done in group homes. So these are essentially orphanages where kids did not have anyone to vouch for them or protect them. And so there were cases where some infectious diseases were spread throughout the homes and they did not provide care immediately. So just trying to see how that course of the disease occurred in the pediatric population. So not treating a medical condition is unethical. The monster study was a psychological study done where the researchers took 2 groups of kids, one group that had a condition where they would stutter and the others did not. And they worked to get the kids who stuttered out of that pattern of speaking, And the kids who didn't stutter, they actually verbally abused them and caused them to actually start stuttering. So again, unethical in terms of what they're doing with that population, where they're predisposing or trying to get kids to have this negative condition. The Hopkins lead paint study, most of you are probably familiar with Johns Hopkins University. So it's one of the premier research universities in the country. There was a study done there. It was actually in inner city Baltimore, where they had children were living in housing developments that had lead paint. And so they knew that there was lead paint in those developments, and they followed the children to see what medical conditions may occur as a result of living in those areas with lead paint. So essentially lead paint exposure, and just seeing how that lead paint affected their health. So again, unethical because they knew there was a risk with lead paint and still conducted the study. The last one is the initial study on autism and vaccine use. So this paper was published in The Lancet, which is pretty much the top medical journal in the world. And it later came about that the individual who conducted the study falsified his data. So he knew children that had autism, knew that they had vaccines. So he recruited specifically those kids into the study and showed that there was a very high correlation with having a vaccine and developing autism spectrum disorder. It came about that he was falsifying the data because multiple researchers tried to replicate his study, and no researchers were finding the results that he found. So they did further investigation into the study, into his data, and found that he was actually falsifying by recruiting people he knew had the condition and also had a vaccine. So that study was eventually retracted. So they removed it from the journal. But at that point, the results had been shared worldwide. So it created a lot of issues in terms of vaccinating kids and thus affecting overall health of the kids later on. And so when you have some of these unethical research practices occurring, it causes trust issues. So individuals may not trust researchers, they may not trust doctors. If you're seeing some of this unethical research occurring, there are also public health implications. So after this study came out, more and more people were not vaccinating their children. So there started to be the spread of some of the diseases that had been eradicated years ago with vaccinations. So there are implications in terms of public health, also in terms of trusting healthcare providers, trusting researchers. And it's really important that, you know, the healthcare system, researchers have the trust of the general public so that we can continue doing research and being able to further the knowledge we have through this research and practice with researchers as well as with medical professionals. Does anyone have questions before I move on to the exercise testing and prescription section? All right, so in terms of exercise testing and prescription, we will go over specifically how to do exercise testing and how to prescribe physical activity in the pediatric population. But there are a couple things that need to be considered that take into account some of the ethics of the work that individuals like myself do. So type of testing, are you going to have the kids do a maximal or peak tests versus a submaximal test where they don't go as hard, there's less risk of injury? It really depends on what you're going to be doing, what your outcomes are, to determine what's ethically the best practice. So if I'm just in a school setting wanting to get the overall fitness level of a large group of kids, I will do some sort of submaximal test that the kids typically do in a physical education class. If I'm working with, say, a clinical population, looking at the effect of different treatments on their aerobic fitness level, I will probably do a VO2 peak test, because that will give us the best information to be able to determine if interventions are working. When we do these tests, especially if we're working with clinical populations, they will be done in a clinic with physicians available in case we have any adverse effects. So with clinical populations, when you do exercise testing, there is always a physician on site in case you have some complications occurring. Choosing your protocol. So if you're going to do a treadmill versus a cycle test, and what type of test is going to be ideal for the child, and what's going to give you the information you need while also providing a safe experience for the kids. And then moving into the prescribing activity, looking at program choice. So making sure that that program is developmentally appropriate for your population. So for example, we're not going to take a preschool population and train them to run a half marathon. So they're not going to be able to run that distance. They're not going to be able to do that activity. But taking a preschool population and teaching them different skills associated with different sports would be a lot less risk and more appropriate for kids in their age range. So making sure you take into account why you want to do the testing, why you want to do the programming, and what's going to be best for the child, really looks at those ethical practices in terms of testing and prescription. So in terms of doing ethical research as well as using appropriate ethics when you are maybe in your job as a healthcare provider. So as a researcher, and like in my lab, I have several undergraduate and graduate students helping me with research. It's our role to protect the child, to do things ethically so that there's low risk to the child. In order to do research at the university, and this is going to be the case at most universities, most hospitals, if you're going to do research, you have to go through specific training so that you know how to protect your participants. So there's a city training protocol that that all my students are required to do. Anyone doing research at UT is required to do this. Some of you may have already done this training. It's about a 3-hour training that can be broken up into, you can sign in and out. But it really goes through the background of ethics during research and what you can do to help protect the populations that you're studying. As a professional, so if you're working in a healthcare setting, in a clinical setting, you're going to have lots of protected health information, private information about your patients and clients. So making sure you protect that information so that the information is not shared, keeping good files, keeping them anonymous, keeping them in a safe place is going to be important, as well as the practices that you choose to do within your clinic or setting, making sure those are ethical and appropriate for the populations that you are working with. So we do see that role. Pretty much the goal is to protect the pediatric population, and we do that in a variety of different ways, both as researchers and as professionals. Here on campus, if we do anything with kids, we have to go through the Protecting Minors program here on campus. And so this program was put into place after, you may remember the incidents that happened at Penn State University, where one of the football coaches was abusing children, and it went unreported for years. Numerous people knew, but nothing was being done. And so in order to prevent that from happening again, most campuses, most schools throughout the country have adopted these Protecting Minors programs. So as part of this program, we have to jump through a lot of different hoops, but it's obviously warranted and necessary in order to protect the kids we're working with. Prior to doing any program, we have to submit an application at least 45 days before we start the program. We give information about what we're going to be doing in the program. We submit what we call a list of protected adults. And so in order to be classified as a protected adult, you have to have a background check, and you have to go through their training program to make sure you understand how to protect the kids, how to report if you suspect or know some sort of abuse is going on. This is primarily geared towards things like camps, overnight programs on campus, but research also falls under this umbrella. For the most part, what I do, we are never alone with the kids. So either the parents are there with us, and then I do work in the schools and at the preschool on campus. In both of those settings, we can never be alone with the kids. There has to be a teacher or an aide or some sort of school representative with us at all times. So that reduces a lot of any risk of abuse occurring, but it doesn't protect us 100%. So we still go through this program for all of our research studies. And what they do is they talk about what's considered abuse. So whether it's physical abuse, sexual abuse, verbal abuse, the training goes through examples of all those types of abuses. And the biggest thing that needs to be kept in mind is, how do you report the abuse? In the state of Tennessee, if you suspect or know abuse is occurring, you have to report it, or you could face charges. So it's considered a felony. In terms of reporting, if you know or suspect some sort of abuse is occurring, you need to report it. First is going to be to the local police department. So you can report to the local police department or a judge in the jurisdiction. So that's your first call or first notification. Reporting it to campus police or public safety should also occur, but after you let the local police or the judge know. Also knowing or providing that information to people in program administration, so people who are in charge of the program, just so they know what's going on and have that background. And then general counsel with the university is always good to also let them know in case you need further protection. So this is the reporting protocol. I have not, in my years of conducting research, I have not had to report any of this. but again, we are also not alone with the kids. In a previous place I was at, I had to report one thing because kids will pretty much tell you anything. If if you're working with them, especially if you're working regularly with them, they'll tell you information that their parents probably would not want you to tell, would not want them to tell you. So I had a case where I was working with girls on the run. So I was with the same kids a couple days a week for weeks. And I had a little girl tell me something that I had to tell police, and everything ended up being okay. But just because there was a I suspected something may be happening, I had to report it. But for the most part, we see kids only for an hour or two, and we don't really see, they're not really telling us much, and we haven't had instances where we saw physical signs of abuse. So hopefully we never have to report anything, but if you need to, this is kind of the chain that you go through. A couple years ago, there was in the state of Tennessee, there was a basketball tournament that was off the school's campus. So sort of a a tournament at a different site where the individuals had to stay overnight or stay in the dorms. And there was a incident of sexual abuse, and the coaches found out. The child had to be taken to the hospital. The coaches did not tell anybody, so they didn't tell administration, they didn't tell police, they didn't even tell the parents. The parents took the kids to the hospital, ended up getting all the information because it was investigated. And individuals, in terms of coaches as well as administrators at the school in question, lost their jobs because they did not appropriately report the information. So they told people in the program, but not local authorities. So that led to them being charged. Some of them lost their jobs. Some of them were able to keep their jobs. So just keeping that in mind, if you're helping with research and that happens, or if you're in your own clinical setting, job setting, to, if you suspect or know something happens, to report it, because dealing with kids, you'll have all sorts of things happen.